Okay, good afternoon, everyone. Hi, this is Ken Sharp with the Iowa Department of Public Health. Thank you for your patience as we get started today. We do have a handful of things to work through today. The same crew that you heard from last week, and then in addition to that, we do have Director Garcia with us today for some opening comments and items that she would like to address with you as well. The first thing that we do want to address, and Director Garcia and I will jump in here as we need to, and as we might see questions pop up. We do again want to just recognize this week has been some very busy week and a lot of changes, and the changes occurring very quickly. And we realize those sudden changes are putting all of you as well as all of us in a very difficult position, and we are doing our best to try to avoid that. However, with all of the considerations that are occurring right now, we just are unable to avoid some of these very short turnaround timeframes. And we continue to watch federal information that's going to continue, I think, causing us to continue to pivot and shift and adjust over the next several weeks and months as we get a clearer image of the Biden administration.
Hey, Ken, I'm going to interrupt you for just a second, and I apologize, but I'm getting text messages from a few people that the link is not working and they're not able to log in. So I think we might want to pause for just a second.
Okay.
Because it's coming through a bit fast and furious, and maybe just see Rob, perhaps as our host, if there's a link that can be recirculated out to our email distribution list.
So, Rob, let's pause the live production, everybody. We'll be back with you momentarily. If we can do that, Rob? We cannot do that. Okay. So, Kelly, let me, are those coming in by email?
No, I got text messages, and I'm asking Faith to follow up on it on her side, but she was able to get in, so her link is working. We'll reach out. I'll have Faith reach out to them directly.
Okay.
Apologize for the interruption.
That is okay. So to the changes that we experienced this week with the shortage order, we want to spend just a couple of moments and acknowledge those changes. As we had noticed last week with the announcements from the federal government regarding the intent for states to have adjusted to the age of 65 and older, we have also been watching states around us continuing to move to the age of 65 and older. And so there's just kind of increasing pressures for us to make sure that we are incorporating that population as we work forward in our vaccination strategies. So in working with the governor's office and thinking through the implications for us, we felt it was necessary to begin to open that population of that age eligibility. Doing so, we also recognize that is increasing the burden and the demand for a very limited supply of vaccine. And in order to better manage the supply and demand, and we recognize this isn't a perfect solution, but we do see in the shortage order 5 tiers now that provide hierarchy in the populations that we are asking you to address in your local jurisdictions. And then the final thing that we wanted to ensure, and we can talk about this perhaps in a little bit more detail when we get into some later slides, is there are 2 pieces of flexibility that we have offered. One is consistent with what we saw in the language that was originally issued last week on Friday, that allows healthcare providers who had leftover vaccines to in a vial that would otherwise be thrown away to use that vaccine on someone in another tier or another phase. In addition to that, prior to February 1st, if we have vaccine providers who have vaccine that is kind of left over, if you will, from phase 1A, and you have some demands locally and can begin to reach that 65 and older population, we are allowing that to occur prior to February 1st with the intent that we focus on the 65 and older because of their higher risk category. There's two other points that we want to make sure that we address. That we received a number of questions about the intent for Hy-Vee's presentation. The perception was that Hy-Vee was going to be playing a more prominent role almost immediately. We want to clarify that we are continuing to watch information from the federal government, and we have some information that has just been revealed in the Biden administration's plan for COVID response that we'll address later. But at this point, Director Garcia and I have had regular meetings with Hy-Vee. Hy-Vee does not have special access to vaccine, and we are not at a point where we are ready to activate on behalf of the state the retail pharmacy program, but we will be continuing to watch that very closely. The intent of yesterday's presentation from Hy-Vee was to simply highlight some of the excellent work that they are doing with many of you at the local level, and to highlight the benefit of partnering with Hy-Vee or any of the other pharmacies that are enrolled vaccine providers, and ensure that we're making that vaccine available in as many locations as we can as supply determines. So we apologize for any unintended perceptions that Hy-Vee's presentation created, but this is not a signal that we are immediately moving to the retail pharmacy program and taking doses away from local public health. The other thing that we've heard back from is the infographic that was shared as part of the press release, or the press conference, excuse me, was across the bottom. There were some chevrons for each of the tiers that talked about locations where individuals might obtain their vaccine. And there was some impression that that intended to exclude certain vaccine providers like local public health or local clinics, and we want to be abundantly clear. There was no intention to be exhaustive on those chevrons or exclusive on those chevrons. It really was an attempt to make sure that the public begins to kind of understand what their options may be as vaccines become more available. And so we are continuing to focus on the IDPH infographic that was sent out, and I've seen many of you using on your Facebook page. And as we begin to see more detail in terms of vaccine allocations, we will try to place more specificity in terms of timelines and those types of details as we get that information in the coming weeks. So with that, I am going to turn over to Kelly for a couple of items. I've got to get my slides advanced. Kelly, over to you.
Thanks, Ken. Good afternoon, everyone. We're glad to be with you today to kind of walk through a few updates. I wanted to pull a particular slide on state employees. So we have been working in close partnership with Polk County, as Polk County is responsible for vaccinating the Capitol complex. And so we, a team member and myself, have been working really closely with Helen and Franny. We're very thankful to both of you for the partnership here to gather numbers for the Capitol complex. And it occurred to us that that might also be helpful for each of you at local public health to have kind of an idea of who is eligible in that 1B category, who are employed by the state, kind of, you know, from our perspective, what numbers are you dealing with in a locality? And so we have packaged that material up together in a way that at least we find to be a bit easily digestible, and we'll be sending it out to all of our local public health entities. Use it as you see fit, and should you have any questions or need any additional information about the employees who are included in that spreadsheet, it's really just numbers and the type of work that they do. In some places you may know who they are, in others you may not, and we wanted to just, again, make it as easy for you as possible. So we'll be sending that out, and we'll put a contact person on that email so that you know who to contact should you have any questions, and hopefully this does make things a little bit easier for you. As you can see on this particular chart, we did work with executive branch agencies, and here in Polk County, the legislature, judicial branch as well, and statewide elected officials to kind of categorize their employees into a high, medium, and low risk category. And so what we're sending to you really is that high category. And we will only be including those who are eligible in this phase 1B priority population. So that's about it for that piece. I'm sure we'll get a few questions on that, and that is just fine. The second item that I really wanted to talk with you all about today is that we have received a handful, maybe a bit more than a handful, maybe about a dozen inquiries about how retired clinicians or clinicians who are not working full time, whatever their kind of family circumstances, offering assistance. How can they help out with vaccination efforts? And of course, that's a tremendous offer, and we definitely want to take them up on that offer. There are a few things we've put several factors on here that we think about when taking on volunteers. Certainly licensure, background checks, and then liability insurance. Because of those factors, I've been pointing some folks to staffing agencies. Staffing agencies can take on folks who just are willing to work for a couple of hours. We have iServe, and we're seeing some level of interest there, but it has not been an effective tool, or as effective as we might think, in terms of pulling in available clinicians to kind of send out to do pandemic-related efforts. So to that end, we really do want to make sure that these partnerships are connected to y'all, and want to think about, how it might be best to get those connections made at a local level. Again, thinking about ease and not further bombarding you with folks outreaching, but definitely connecting you with individuals who are either willing to offer assistance for free, perhaps, or are available to help you in your just general efforts. So we are cataloging that information too. In some cases, I've sent a few of you, a little note on some offers that have been made directly to us, and we will continue to work on that effort. If you have additional suggestions of how you might want to receive that feedback, please do let us know. We're paying particular attention to it as we think about standing up clinics. And with that, Ken, I think we're ready to turn it over to Bethany. Great,
thank you. Bethany, next slide is yours.
Great. Good afternoon, everybody. As Ken mentioned, it was a week of sudden changes, but for the good news is there wasn't a lot of changes with our clinical guidance. This is just your weekly reminder that we want you to finish your booster dose with whatever brand of vaccine you started the prime dose with. The series they are not interchangeable. And just as I've mentioned before, COVID-19 is a new vaccine. Any administration errors, go ahead and report those to VAERS. Next slide, Ken. So we've had a lot of questions about if the person has enrolled in VSafe, if we go ahead and complete a VAERS. Yes, anytime that you feel a reaction is worthy of being reported to VAERS, please go ahead and report that regardless of if the vaccine recipient had enrolled in VSafe. Next slide. Just a reminder on VSafe, please encourage your vaccine recipients to sign up. They do get a reminder for their second dose when their second dose is due, and this is just CDC's way of following them up and monitoring on side effects of the vaccine. Next slide, Ken. We've had some questions on the pre-vaccination screening form. There is now a Spanish version available. We have this posted out on our website, and it is available on the HON for our local partners. Next slide. I am sure a lot of you heard earlier in the week, California raised a concern with a Moderna lot number that they felt that they had seen an increased reaction at one of their community clinics with, and they recommended pausing the use of that lot. On the 21st, yesterday, they came out and they had gone and met with the FDA, the CDC. They have a work group of the Western State Scientific Safety Review. They all met and they looked at all of the data, and they have found no scientific evidence that warranted the continuation of the pausing of using that lot number. So they were advising their healthcare providers to go ahead and resume using the lot number of Moderna. And so I know we had a lot of questions on that. CDC had indicated that they did not want us to pause using, you may go ahead and resume using that lot number. Next slide. And I believe I'm kicking it over to Don.
Thanks, Bethany, and good afternoon, everybody. I want to talk to you a little bit about the Pfizer vaccine and obtaining that 6th dose out of the vial. Just as a reminder, the low dead volume syringes or needles will consistently ensure that you get that 6th dose out of those vials. If a standard syringe is used, you may not get that 6th dose. So it's important to use the supplies in the ancillary kits. Also, early testing shows that if you use a combination of the low dead volume syringes in conjunction with the standard needles and syringes, you still will get that 6th dose out of those vials. So the combination of 3 low dead volume and then 3 standard syringes will still yield that 6th dose. Ken, next slide, please. Which brings me to speak to the ancillary kits. CDC is prepping the ancillary kits moving forward to make sure that all providers can go ahead and get that 6th dose out of those 5-dose vials. Also want to remind you that each dose must contain a full dose of vaccine. So it must be that 3 ml dose that you must be getting. If you do not get that 3 ml dose out of those syringes, please discard those syringes or discard those vials of vaccine. They should not be utilized. Also, just a reminder, which we've been talking to you guys a lot, you cannot utilize those pooled vaccine from multiple vials to make up a full dosage. So it should only be getting those doses out of a single vial of vaccine. Also, while the number of syringes in each ancillary box will increase to support the additional doses, there may be situations where you'll not get those that extra dose out of there. So if you do get an extra dose of vaccine, the flats for the Pfizer come in 975 dose increments. They will be transitioning those ancillary kits to include 1,170 components, along with some overfill as well. Next slide, Ken. Which brings me to talk about the IRIS inventory. So we are currently working on updating the number of doses that will be yielded from each vial of vaccine. We've been working with CDC, our federal partners, about making that change in all of their systems, as well as the state system. So hopefully here in the near future, we'll be transitioning from 975 doses, that 975 dose increment, to 1,170 moving forward. So we'll provide some additional guidance once we get that information from CDC and their partners, as well as when we'll transition to that. So we'll provide some additional correspondence once that's available. If you do ever have any questions regarding your inventory in IRIS, by all means do contact the IRIS Help Desk. The number is included there. They'd be happy to help you walk through any of your inventory issues and making sure that your inventory is accurately documented in IRIS. Next slide, Ken. So speaking of transitioning into 1B, I know Ken was talking about that earlier and the amount of vaccine that we'll have available. Vaccine allocations moving forward will continue to be allocated by CDC to us based upon our populations, as well as utilization of COVID vaccine. So we need to make sure that we're appropriately documenting doses administered in IRIS as soon as possible. We will also be looking at the county allocations. We'll look at the priority group, the populations that we're serving. We'll look at your doses administered and the doses that are in inventory for the entire county. So when we're looking at inventory, we will also not take into consideration any boost doses of vaccine that have been sent to you. So we'll exclude that from what we're looking at. So just as a reminder, it's really important that all doses of COVID vaccines administered, as well as doses that are wasted, need to be documented appropriately in IRIS. We have instructions on the IRIS, or I should say on the webpage under the IRIS instructions section, as well as the HAN, about how you document doses of vaccine that have been wasted. We need to make sure that your doses that are distributed, doses administered, and your inventory on hand match up as much as possible. Next slide, Ken. Also want to talk to you a little bit about redistribution. I know we've talked about this plenty of times previously, but I think it's important to continue to revisit. Any redistribution among healthcare professionals does require approval from the department, and also that redistribution must occur between IDPH enrolled COVID providers. We want to make sure that that is not going to anybody else that has not been authorized to be a COVID provider in the state. We've also been asking that you try to keep your doses in your county. We have approved some of those redistributions or transfers outside of counties when the local public health agency has been involved in that. We are allocating by county, so we want to make sure that all the doses that you're being allocated does stay within your county to vaccinate your populations. Next slide, Ken. Just a reminder about the redistribution. We have a form that's on the webpage. Send that redistribution form to the COVID-19 vaccine email address. We will approve those within 24 hours. We're actually turning those around probably greater than 90% of those within an hour. So we have a very good turnaround time and a lot of staff paying attention to that inbox and can go ahead and respond to your requests very timely. We as the state health department will log into IRIS for both the transferring and receiving organizations, and we will handle that transfer on our side, so that way you do not have to worry about that. You as providers then only have to worry about the transfer of those doses, as well as any ancillary supplies, that physical transfer, to make sure that that is completed. Next slide, Ken. I want to talk to you a little bit about vaccine administration and data visualizations. The web page that is being displayed is where you can see those visualizations. We are currently posting static visualizations Monday, Wednesday, and Friday. However, we are working with Domo to make a more interactive visualizations and some additional details as well. So that will be hopefully coming here in the next few weeks, and we'll have that posted up there as well. Next slide, Ken. Just a reminder about resources and materials. As we do get new information from CDC as well as the vaccine manufacturers, we are keeping the webpage up to date. We are trying to break that down into some basic sections so you can find that information more easily. The bottom of the page includes the link to all the vaccine information, and any questions that you have can be answered with the information that is there. If you also have any questions by any means, give us a call at the 800 number, or you can also email us at the COVID-19 vaccine email address, and we can help point out any of those resources that are available on our webpage. Next slide, Ken, and I believe we're turning over to Rebecca.
Thanks, Dawn. Good afternoon, everyone. So let's just talk real quickly for some quick updates on the pharmacy partnership for the long-term care program. So as most of you know, the pharmacies began vaccinating in the long-term care centers the week of December 28th. So as of, we had updated numbers this morning. We are updating the numbers daily, but as of the 20th, as you can see on this slide, the long-term care centers have administered over 39,000 doses. So that's fantastic news. And all of the pharmacies are expected to have 100% of their first clinics completed by the end of January. So the current status is what you can see there below. We feel like they're starting to pick up. We're doing our best to stay in touch with them and working with them as they continue to move forward through the program. So quick updates on the federal retail pharmacy partnership. I know Ken talked about this briefly in his opening slides, but the last information we had prior to receiving the information from the Biden administration just early this morning is that we will just continue to encourage all of you to work with your local pharmacies, hospitals, and your clinics to increase the access to the COVID-19 vaccine that we currently have available. We're not allocating doses to pharmacy at this point, or asking CDC to allocate them directly to the pharmacies yet, because of those strong partnerships that we know all of you have with your pharmacies and the number of pharmacies that are currently enrolled with us and with you as COVID providers. So at last information we had, that the federal allocation to those retail pharmacies wasn't expected to be activated until probably the second week in February, but additional information will be forthcoming as soon as we can get it. So the next slide, we want to talk a little bit about the funding that we are receiving for vaccination and immunization efforts. So the state of Iowa is receiving a total of $28 million for vaccination efforts. This funding will be available through 2024. So we are considering various different options for utilizing this funding at the state level as well as at the local level. So we are talking through some different concepts related to strike teams, additional data visualization efforts using Domo and other non-static type vaccine administration reports for all of you to see as well, looking at different staff augmentation and support as well as the local contracts. So we've been working over the last couple of days to get the contracts in place. So utilizing our preparedness and response contracts that you currently all have at the local public health level, and contracting $10 million. So we expect to be working over the next couple of days, trying to get those out to you by mid next week. We will be using the funding formula that we typically use for the preparedness contracts, so 50% base and 50% population. There will be specific performance measures, just like in all of our contracts. There will be an appendix that is provided that allows you to understand what activities you can use these funding efforts for, and then including the subcontracting options that you can use with vaccine providers. So if we can go to the next slide, Ken, we'll talk through a little bit about the objectives that we have from our federal partners. So the grant award, we had 5 days to accept the award, which we did. So the objectives and the expectations of the funding will be to increase the COVID vaccination capacity across the state, including among high risk and underserved populations. And we do have to demonstrate that at least 10% of the funding that we're provided is specifically based on making sure that we address the high risk and the underserved populations. So these are pretty broad. I'm not going to read through these. You guys can read through these, and these will be reflected in the contract and in the appendix where the eligible activities are. So as we said, the contract information to the local public health agencies will be forthcoming. And again, hope to get the drafts to Ken and our administration really early in next week, and then to get those out to you just as quickly as we can after that. So I will turn it back to you then, Ken.
Great, thanks, Rebecca. So we want to spend a little time on the vaccine shortage order that was issued originally on the 14th, and then we've modified the supplemental order that we issued last week on the 15th for, and it was replaced with the order that was issued yesterday. We want to just walk through a couple of key things. There are some nuances in this we want to make sure everyone understands. Phase 1B as a whole will still not become eligible until February 1st. We also recognize that there are vaccine supplies out there that we don't want sitting on a shelf until we can get to that February 1st date because of various circumstances that you all have explained to us. There are a couple of flexibility items that we will discuss here, and I'll cover those as we work through the shortage order. If you have the shortage order handy with you, feel free to pull that up and I can walk through some of those items as we get through these slides. So just a reminder, we currently are and will remain in phase 1A. And phase 1A populations are healthcare personnel as well as residents of long-term care facilities. One of the things that we want to be sure to clarify is that as we transition to open eligibility for phase 1B populations, phase 1A recipients can still access vaccines if they've missed this first roughly 6 weeks of vaccination efforts. So there will be an opportunity to continue to receive that vaccine. If you have someone that is a healthcare personnel that did not get their vaccine after and they show up after February 1st, it is perfectly appropriate to continue to offer them vaccine. So for the update that was issued yesterday, and you all should have received it, it is also posted on our vaccine provider webpage. There are some key things that we want to focus on, and we'll work to kind of clarify a few questions that we've been hearing as themes as we look at these eligible populations. The first thing, and we acknowledge this in the opening comments, originally we were focused on 75 years of age and older. However, after continued, I think, pressure from our federal partners and continued expansion amongst our peer states and neighboring states to offer vaccine to the age group of 65 and over, we felt it was necessary to try to align ourselves to better align with those federal expectations and to help reduce confusion, particularly in some of our border counties that have states next to them that are targeting 65 and over. We want to make sure that this organizational structure in the shortage order is not suggesting that you start first with 65 and over and then move to the tiers. We are really asking you to begin working on both the age-based eligibility population as well as then the priority populations, which are further tiered for prioritization. So beginning February 1st, we want to target anyone over the age of 65, as well as begin working on Tier 1. I think from what we have seen in your social media that we've been watching, you guys are doing a great job at the local level trying to articulate to your residents that the vaccine supply is just not such that anyone over the age of 65 will be guaranteed vaccine that first week. And we anticipate that the 65 and over population will be drawn out in terms of vaccination efforts over a many-week period as vaccine supplies become more available. In addition to that, then, as we've stated, the tier populations that we have organized is to try to help you at the local level provide some prioritization that will help communicate to your partners and to also attempt to help kind of govern the control of supply and demand. And so I won't go through these explicitly. These are the tiers and the populations that are within the tiers have not changed from the shortage order issued last week. We have simply organized those in order of preference as you work through those populations. There have been a few questions that have popped up. One of the things that we are going to work on clarifying and addressing is some confusion that is occurring between, for example, Tier 1 and Tier 5. And I'll just kind of flip back and forth between these two slides so that we can reference that and just address what we are already hearing as some common questions. Tier 1 is inclusive of first responders, which includes police officers. And the correctional facility staff and individuals incarcerated, including all levels of facilities of government in Tier 5, we have received a number of questions, and these are very fair questions, about where do correctional officers, jailers, and others fit. There has been some strong opinions that those individuals fit more appropriately with first responders. We will be working on developing some consistent guidance on that and look for that in the coming days. In the Tier 2 population, there's a couple of things that we want to clarify that we will receive questions on and have received questions on. The individuals with disabilities living in home settings that are dependent on attendant care staff and their attendant care staff is really focused on those individuals who do need attendant care, regardless of whether they are in very small home settings or a much more congregate-like setting. But the key focus here is on that attendant care need. This isn't necessarily intended to be family members living with someone who has a disability, but certainly individuals with disabilities will be eligible as we work through Tier 2.
And can I chime in there? So I would say that in some spaces, I mean, on the Medicaid side, we have a lot of family members who are the attendant care. So just, it doesn't mean, it's not intended to be everyone who is living in a house. It's really meant to be that very much direct care. Which could be a family member.
Yeah, good clarification, Kelly. Thank you. And then on the frontline essential workers in these agricultural, food, distribution, and manufacturing sectors, I did see a question. We have continued to receive questions. The priority population here that we are working on for Tier 2 are those who work or live in congregate settings. So one of the things that we discussed early on, and this was prior to the issuance of the the shortage order last week, is what about the family farmer? He's in food and agricultural production. Yes, that is true, but that is not the intended audience here. It really is, we want you to focus on this congregate settings for individuals that work or live in those congregate settings. So for example, migrant workers who come in and are in congregate settings because of their living arrangement, or the nature of the work in the manufacturing or agricultural setting, like meat processing plants and other types of settings, are what we are intending to target. Others outside of that population are intended to be addressed at a later point in time that we have not yet defined. So the Tier 3 is really kind of the catch-all for others living in congregate settings in a variety of options. It is not intended to cover college dormitories. Government officials, there's been a number of questions related to this. That this really is, and I see there's a typo here. I apologize. There's some leftover language at the tail end of this that wasn't intended to be. So our apologies for that first set of bullet points. The government officials are really targeted for those government officials that are in the state capitol and working. This was not intended to be all elected officials. And so this will largely be focused around the metro area because of some of the policies that are in effect in the state capitol. And then Tier 4 and Tier 5 are pretty well defined by themselves. I want to maybe just spend a little bit of time, in addition to the phases, I want to address a couple of additional things that we addressed in the flexibility efforts that we are attempting to work through. As we have stated many times before, as we were working through Phase 1A, we were working very hard to maintain the entire state on a similar phase status. The reason for that was the focus on the healthcare system. If you have the shortage order in front of you, and if you look at paragraph 2, there will be some more flexibility, and this will create some variation from one county to the next as your county begins to move through the various tiers. And we want to be sure everyone understands that counties will have discretion to advance through the tiers as their populations are vaccinated. We recognize this will create some confusion locally. However, based on the discussions that we have had at the state level, we feel it is very important to, at this point, move as swiftly through vaccine as we can. And we recognize that that will create some additional inconsistencies in where counties are with their vaccination strategies. So we want to just be very upfront and recognize that, but we do want to call that out in the paragraph 2 language. In the paragraph 3 language, we do have a couple of options for flexibility that we want to make sure that we address. One of those was in the shortage order that was issued last week on the 15th, and that is the issue of having residual vaccine available in a vial. Where you're offering a clinic, perhaps you had 3 no-shows and you have 3 doses left in a 5-dose vial. We are giving you discretion to make your best judgment on where and how to use those 3 remaining doses so that they do not go to waste. And that does allow you to focus on individuals or access individuals that are not within a current phase. However, again, as we've stated before, we're asking for you to ensure that you use discretion and make the best possible judgment on who should receive that vaccine. The new addition for flexibility is very specific related to the time frame between now and February 1st. we have heard from a large number of healthcare providers who were given an allotment of vaccine of, say, 100 doses of Moderna, and they were able to complete their phase 1A and have some vials still available, and would like to begin providing vaccine to their 65 and older population as those individuals discharge from the hospital, for an example. So we do have this language added in paragraph 3 that if your county has satisfactorily moved through the 1A population and you have doses available, we will allow you ahead of February 1st to vaccinate individuals over the age of 65 or 65 and over, so that we can begin getting that vaccine moved ahead and in arms ahead of the February 1st start date. We do not want folks to wait unnecessarily when we are this close to finishing up phase 1A. The other thing that I'm going to take just a moment to discuss here is we have for the last 3 weeks, and this will include the shipments of vaccines that you will all be receiving next week for those of you that received an allocation. We have been intentionally targeting increased allocations to counties who indicated they still had phase 1A populations to vaccinate. As we approach the allocation notifications that you will be receiving next week for the shipments that will be arriving the week of February 1st, we want everybody to be sure to understand a couple of things. First and foremost, for those of you that have vaccine that are still available, and if you begin to focus, for example, on that 65 and older population with the flexibility language that I just addressed, or even if you wait until the week of February 1st to begin using that vaccine that you have in your inventory currently, there will likely be a brief bubble of additional doses for those counties that had additional doses remaining in their inventory. As we work on our allocation for the vaccine that you will be receiving the week of February 1st, we are returning to a population-based allocation for at least the first 2 weeks in February. So that will mean for the first week in February, we are going to have something less than 39,000 doses because we still have a balance to pay off for the National Long-Term Care Pharmacy Program, but it is more than 19,500 doses of Moderna that we have been allocating. So you will be receiving a population-based allocation. And so when you take something smaller than 39,000 and divide it by 99 counties, we want to make sure everybody has a very pragmatic view that the doses that will be shipped to you the week of February 1st and February 8th is not going to be enormous numbers of doses. So we want you to be thinking about that as you work to communicate with your public. As we get through the first couple weeks of February using that population-based allocation model, as we start to look at burn rates of vaccine by counties, and this gets to some of the information that Don was talking about in our overall allocation strategies, we will begin to make adjustments, if necessary, to drive additional vaccine to additional areas. And that may result in some disproportionate allocations as a result of overall burn rates in individual counties. The other thing that we want to just have folks thinking about as we move through the weeks of February, perhaps into early March and perhaps beyond, depending upon what happens with allocations, and as we approach the Tier 2 populations, we know particularly for the Tier 2 populations that are in the congregate work settings for those various agricultural, industry, and manufacturing settings, we are hearing very consistently that those employers wish to have employee clinics at their place of employment. That will cause, for example, a meatpacking plant that is in a small rural county that would, on a population-based approach, receive a small dose of allocations, may need to necessarily see an increase of allocations for a week or two in order to support that employer-based vaccination clinic. So we are working to gather that information. We have a lot of information from several manufacturers about the number of employees that they have. We have information from Workforce Development and Department of Agriculture on those employment centers. And we will be working to try to ensure that we target allocations to those counties that have major employment centers, similar to what we did for those counties that had major employment centers for healthcare systems. Again, this is not likely to have much of an impact before the middle of March, but again, it is all highly dependent upon the timing of the allocation increases that we may see. So we cannot give you a precise date, but we do want you to be thinking and realizing the first several weeks we're using population-based allocations. And with the doses that we know that we will be receiving, there's not going to be a lot of doses in any one county. And then as we transition and begin to focus on allocations for Tier 2, there will be some allocation strategies that will drive more doses to those counties that have major employment centers. So please be thinking about that, be anticipating some of those changes. We will do our best to signal to you when some of those strategies may be in place. We do not have a time frame yet on when to expect that. We have indicated we were hoping to get the Q&A out to you this week. We've not been able to do that. We recognize that some of that is due to the changes that occurred this week, but we will work on getting that Q&A document to help answer some of the questions and the common themes that we're getting. And we will work to get that out to you next week. These are just some reminders. I don't want to hone in on these and dwell on these items too much. We discussed these last week. We recognize everyone is in a very difficult spot answering very difficult questions and having to tell people difficult answers of no. And that's very discomforting. It's very hard at times, and we recognize that. We just ask everyone recognize we are all doing our best in making those decisions. And we ask you to do the same and do your best to interpret the guidance. One other thing I want to come back to for just a moment with respect to Phase 1B and the shortage order. We have also received a handful of questions regarding the IDAC recommendations for a 50-50 allocation of the vaccine that is distributed. We want to make sure that we kind of clearly articulate in terms of the requirements for a 50-50 allocation. Those that language was not included in the shortage order. The shortage order is the only kind of legally binding document that is out there, and we did not include the 50-50 allocation in the shortage order because we recognize, particularly in the early weeks when the doses are very limited, it may not be practical to have a perfect 50-50 allocation across the age-based and the workforce priority populations. So much like the questions about who qualifies for various phases, please consider the IDAC recommendations as simply that. And our message to you is this: as you receive your allocations, please do your best to begin vaccinating both the age-based populations as well as the populations that are identified in the respective tiers. And understand we're not going to be measuring precisely if you received 100 doses that you had 50 go to this population and 50 to go to the other. That is not our intent, and we intentionally did not include that in the shortage order so that we could allow you that flexibility to make the best decisions locally for your vaccination strategies. So again, do your best. We ask that you try to work through and make sure that you're making vaccine available to both populations, recognizing it is going to be a period of time for us to get through these phases and tiers. Again, we recognize it is very difficult. Everyone is doing a great job. You will be perfectly fine in making reasonable decisions and judgment calls, and we encourage you to do so, and without having to feel like you have to check with the Department of Public Health on every single decision that you're making. We are going to be very reasonable in our interpretation of your efforts. And as long as it isn't a blatant disregard for the shortage order, you will be fine in your decision making. I do want to take just a few moments, and I intentionally did not provide a lot of detail on this slide because simply we don't have a lot of detail. So there may be some of you that are aware that President Biden did release yesterday his national strategy for COVID-19 response. I do want to highlight just a few things that we are watching very closely that are particularly outlined in his goal 2 related to vaccination strategies. There are a couple of things that we are waiting some additional guidance on and additional details. We have talked to you before, particularly as it relates to the retail pharmacy program. It has been, as Rebecca had stated earlier, our understanding that the retail pharmacy program would not be activated by our federal partners until we reach phase 2. And the soonest that that was being discussed was perhaps as early as the middle of February. However, in the Biden document released yesterday, they do state by February 3rd, we'll begin program with local pharmacies. And that is all that is stated. We do not have any level of clarity, and we would trust that if there was intent to start pushing vaccines through retail pharmacies on February 3rd, that we would have some indication of that detail. We have not received that at this time. So please be aware, we still do not have details. We will continue to watch that very closely. And as soon as we have any level of clarity regarding the intent for activation of the retail pharmacy program and direct allocation to pharmacies, we will let you know. The next item that I want to just draw to your attention, this is particularly for those counties that have federally qualified health centers located in their jurisdiction who are also vaccine providers. There are indications that the Biden administration intends to directly allocate vaccines to the FQHCs. Again, we do not have details at all at this time as to when or how much or from what supply that allocation would occur, but that is identified in the national strategy. There is also indications in the national strategy to expand the long-term care pharmacy partnership for additional congregate settings, such as homeless shelters, jails, and other high-risk congregate settings. So again, one of the things that we continue to have is conversations and watching very closely from our federal partners, but again, no level of detail or specificity as to how and when that might be activated. And I will tell you, in the conversations that Kelly and I and the governor's office have had with our long-term care pharmacy programs, they have not mentioned any details of this expansion either. So we are very much in a hurry up and wait mode until we have additional details. The final thing that I will share, and we will be working with our state Homeland Security office to understand this, there will be apparently an expansion of eligible funding reimbursement criteria under FEMA. And as soon, again, as we have some more detail on that, we will be working with our state Homeland Security office to communicate to both you and your emergency managers so that you can appropriately document and report those local expenditures that you might have related to vaccine efforts. I think those are the highlights that I wanted to call out. There are a few other things that they mentioned, but those were probably the most notable. These are things that we have been hearing about, and I know that you've been asking questions on. I will just tell you, in the last 2 days, my staff have been bombarded with questions from our CDC, HHS partners, as well as FEMA, asking for information. So I'm optimistic that as those inquiries or those requests for information come in, that there will be a realization that in Iowa, we feel like we are in a very good position. We simply need vaccine. And that has been our consistent message to date. And until such time we have adequate vaccine to truly test our system, we are cautious about bringing in additional FEMA resources until we have assurances that the vaccine can meet the demand. So with that, I see that we have well over 100 questions. This concludes the slides that we have. I will just pop up for our vaccine providers the information that has been distributed many times. This is not intended to be open for the public. The general public should call 211. So this is for the vaccine providers that are on the call and healthcare providers that may have questions related to vaccines. And I believe that is, yes, that is the final slide. So I'll go ahead and leave that up as we work through the question and answer. And I'm gonna stop here for just a moment and check in with my staff. We'll work through the published questions. I think if I don't see a response that you guys have already added, are you guys comfortable with that? Dawn, Bethany, Rebecca? Okay.
I think so.
So there is a question here from right at noon regarding the Binax Now rapid testing program. That is not information that we have available with us today. There is some information being shared tomorrow by Dr. Michael Pentella from the State Hygienic Laboratory on the school administrator webinar. Local public health folks, you should have received an invitation to join that webinar. So there will be some information available there. And we will ask our EPI partners to also address the Binax Now questions next week on the Tuesday meeting. Will groups within each tier be prioritized? If so, are they in priority order now? No, not necessarily. The intent here is to just try to lump populations together. So we want to leave discretion to you at the local level that if you are working to vaccinate your school officials as well as your law enforcement and first responders, please, again, use your best discretion on how best to manage that that population movement. The other thing, and I addressed this to a degree, will the state be telling us when we can move between tiers? No. As we discussed in the vaccine shortage order, please reference paragraph 2 in the shortage order. It does talk about allowing vaccine providers and counties to advance through the tiers as they complete one tier and move into another. We do, again, I want to acknowledge this is a change in our policy from where we were in phase 1A. And the main reason for that is we felt it was important as a healthcare system to have that healthcare system fully vaccinated before we moved into the subsequent tiers and phases. So there will be more discretion for counties to advance through tiers. However, please understand, as we begin to get into particularly tier 2, there will be strategies of allocation that we administer at the state level that will perhaps slow down some advancements in counties that do not have those major employment centers, so that we can advance enough vaccine to those employment centers so that they can carry out their vaccine strategies. I'm going to scroll through a few more here that I see have not, or that have been answered. So the next question I'm going to address, farmers think that they fall in the next phase. Do they? The answer to that is no. The intent really is for those employers in agricultural, manufacturing, and other types of settings that are in congregate settings, either in living arrangements or in work arrangements. So the next question is a bit of a repeat. In the new priority tiers, are you recommending that we do the folks who in those tiers are at highest risk for severe illness or death, or do we just work on those? Again, use your best judgment here. I think when we get into some of the larger priority populations, if you can try to work and get those that are at highest risk first, great. We recognize the supply and demand is going to be such that there may not be an ability to pragmatically prioritize those groups within the respective tiers. So again, make your best judgment call locally. If you do have a particular population that you know is at a very distinctly higher risk and you want to advance those through the vaccination efforts first, that makes good sense to do so. But there is not the same level of expectation in terms of that prioritization within the tiers. Okay, I'm scrolling. Bethany, I'm going to turn to you on this one. So the question, is there anything special about how to provide a booster with someone who has received their primary someplace else or coordinated with other states, specifically if they are not yet eligible in Iowa but have gotten their primary dose in another state? How do you handle their boost?
Well, we would want them boosted for sure, because we know that the second dose is needed for the immunity. You may have to use some of your prime vaccine to cover that booster dose. I hope that these are not typical situations that you are running into, but we would want you to go ahead and provide that booster dose at this time.
Great, thanks, Bethany. We'll take a close. So the next question, there are groups that were listed in the initial 1B that are not included in the tiers. For example, transit drivers. We'll take another close look at that. I would have to go back and look at the shortage order that was issued last week as to whether or not transit drivers were listed. I don't believe that they were. I think this may be a misunderstanding between the ACIP recommendations and what Iowa advanced in the vaccine shortage order. So please take a current look at the vaccine shortage order that was issued by Iowa yesterday and compare that to the ACIP recommendations, and that's the Advisory Council on Immunization Practices from CDC. Those are two different documents and distinctly different. I think that may be where that confusion is coming from. When having volunteer vaccinators, would they need to have their own liability insurance? Rebecca, I know you've worked through this and I know that there are some exemptions. Can I have you address this question, please?
Sure. Under the PrEP Act and several other liability type proclamations from the federal government as well as the state government, these things have been addressed, and particularly for volunteers under Good Samaritan laws. So Heather Adams has provided several documents in the past that talk about these liability exemptions. So we'll get those out in the next couple of weeks because those are great questions. But we'll get those out again. I think she just updated them like a month or two ago. So we'll get those sent out again.
Okay, Rebecca, stick with me because I've got another question for you. It says, we were told during a regional meeting that we cannot bill for vaccine administration, Medicare or Medicaid if we use volunteers. Is this true? And Kelly, this might be one that you can help us with as well, since it's specifically related to Medicare, Medicaid. So the question is, if volunteers are administering the vaccine, can the facility bill for that administration? Rebecca or Kelly, can you help on this question?
I'm not sure where that directive is coming from, and it's certainly not anything that I've been asked to address, so I can certainly follow up, and maybe Kelly has more information.
So we can double back and ask on the Medicare side. That's not our bailiwick, but in general, you have to be an enrolled Medicaid provider to bill. So volunteers, we'll take that back and make sure we provide clarification at next week's briefing. I think you can bill under the parent, like the parent organization, but we will take it back and bring a more kind of technical answer to the group and see if we can get some information on the Medicare side.
Yeah, that would have been, as long as the volunteers are working under an enrolled provider, it should be okay. But yeah, I'll look into it. Thanks, Kelly.
Okay, thanks, Rebecca and Kelly, appreciate it. The next question is, can we include city waterworks in phase 1B? No, they are not eligible in phase 1B. Those individuals will, in the ACIP recommendations, were in the 1C group, and at this point, IDAC has not made a final decision with respect to these water supply operators or even other types of city municipality workers. So no, those individuals are not currently eligible. What is meant by individuals with disabilities living in home settings? I think we did address that. We'll just kind of reiterate what we discussed as we move through that 1B. So individuals with disabilities, we would suggest perhaps looking at the ADA definition of disabilities, and then living in home settings, that can be broadly interpreted. The key information there is that they have direct care staff, and those direct care staff, who may also be family members, would be eligible. So it is direct care staff and individuals with disabilities living in home settings with those direct care staff.
And Ken, to add on to that, so that's going to be, I think from a more technical perspective, that's going to be individuals on Medicaid living in home and community-based settings. So receiving home and community-based services. And I'm hopeful that we will be able to bring our managed care providers into this forum as soon as next week to talk about how they can augment, to the extent y'all need them to assist in delivering vaccine for those homebound individuals. We're talking about people with intellectual disabilities, mental health conditions, or physical disabilities that are living at home instead of an institution.
So there's a lengthy question here. Are there any state pod insurance waivers for a county if the pod is in a vacant department building since this is a pandemic? Rebecca, I believe that some of the early proclamations included some various waivers of liability for very generic purposes, but can you help with this specific question, or do we need to research this more and get back on this question?
I'm pretty sure that that is addressed in the liability document that Heather Adam has prepared for us, so I'll pull that back out and make sure it is.
Okay, thanks, Rebecca. I appreciate that. Okay, bear with me as I scroll through questions that have already been addressed. Looks like, okay. So the next question, for food, ag, and manufacturing, are we to vaccinate all of their employees or only those that cannot social distance while at work? It really is targeted for those operations that have employees that are in congregate settings. You know, my take on this is similar to kind of the issue with the long-term care program. If you're in a facility and you've got 2,000 workers that are in congregate settings and they have another 50 office staff, it doesn't make sense, in my opinion, to go back 2 or 3 different times. And again, this is a situation where I would say to you, make your best judgment locally on how to manage that population and move forward. And so really the intent here is that those individuals that are in those congregate settings are at the highest risk, and we need to ensure that that industry is still operating effectively. And so again, make your best decision here and move forward. Are livestock truck drivers included in, it must be the 1B tier, as they have close contact with congregate workers? No, at this point, truck drivers would not be included. What is going on with the strike teams? How will this affect allocations? So good question. There are a number of items that we are still working through on what this might look like. We don't necessarily envision a testing strike team like environment that we used earlier, but that there may be some options of that nature. And there's also some considerations of just making more broadly available resources to support your local vaccination efforts in community clinics or those types of things. So we don't have enough specificity to offer you in terms of what those strike teams will look like. But as soon as we do have a few more ideas formed up, we will be sure to let you know. Okay. All right, I see maybe the last couple of questions. When we host a clinic, should we continue to schedule second doses as we have been, or are we now supposed to be giving as many first doses as possible? So here, and Bethany and Don jump in on this, until such time that we have direction that changes from our federal partners about how they are going to allocate doses to us, you should continue to schedule and plan for that boost dose for those individuals that you have already issued a prime dose to. So continue to work through that boost dose for those that you are already aware of. We are awaiting guidance from our federal partners about how they intend to allocate and whether or not that will mean we will get all doses at the same time. There are some indications that that might be the strategy. We have a lot to work through to understand how that impacts our practices, but at this point, I believe our recommendation is to go ahead and continue to offer those boost doses for those that you have already issued a prime to. Bethany and Don, any additional context that you want to put there?
I think you covered it well, Ken. Thank you.
Okay. Bethany, I saw you reach for the mic. I'm going to pause for just a moment.
No, and just that we will continue to tell them in their HON message if it is a prime allocation or a boost allocation, so they will know what they are receiving.
So Rebecca, I'm going to turn to you on the next. With the monies the state was awarded for vaccine relief, is IDPH seeking applicants through grants.gov? How is the state? So I think there's maybe a two-part question. Rebecca, let's talk about the $10 million in contracts we will be issuing. If you can revisit that for just a moment of how we will use the response contracts for local public health and then the option for subcontracting. Can you address that? And then I'll come back and address what I think may be a second part.
Sure. So we currently have response contracts with all 99 local public health agencies. So as we typically allocate the funding for the preparedness program, it will be based on a 50% base and a 50% population. So we will send that out as an amendment to that local individual county response contract. And each one of those local public health agencies then, just as they do with all contracts with local, with the Iowa Department of Public Health based on the contract's general conditions, may subcontract those funds to other local partners. And using, again, those requirements within the general conditions for those subcontracts. Does that answer the question, Ken? Yeah,
it does largely. And Rebecca, I'm sorry, I didn't include the context of will that application process be managed through grants.gov?
It won't be an application process. It'll be the just an amendment to your current response contract.
Okay, thank you, Rebecca. So beyond the $10 million in contracts to local public health, and we are giving local public health the decision authority to identify subcontractors within the county with your vaccine partners as you deem necessary. I think perhaps another question here is, will there be other grant application opportunities above and beyond the $10 million? At this time, we do not have intentions on that. We are continuing to explore where that that remaining balance of $18 million will be spent. And we do have some flexibility in where and how we are going to consider that. So we're continuing to work through some of those discussions internally. There will be dollars kept at the state level, and then we will continue to monitor the use and need of the local contracts and continue to navigate and make decisions about that funding. But at this point, there will not be unique grant application opportunities. I believe may have been part of the question.
Yes.
So the next question, for pharmacies doing in-store immunization, can we also immunize the rest of the team in the store in addition to the pharmacy team? These workers are also exposed. I think it would be appropriate, certainly for the pharmacies that are the pharmacists that are administering the vaccines. It would not be inclusive of grocery store workers, for example, if this pharmacy is co-located in a grocery store. So again, make your best judgment in terms of who those individuals are in that pharmacy location. but we have clearly articulated in phase 1A, the vaccinators themselves would be eligible for receiving a vaccine. So I've addressed this to a degree. I'll come back and visit it again. IDAC recommendations were 50-50 allocation. Is that for IDPH or locals? Please clarify what this means exactly. I did describe that earlier, but I'll spend just a moment on it again. We did not include this 50-50 allocation language in the vaccine shortage order. So this does not obligate you to a 50-50 allocation. However, we still feel strongly that this is a good guidance, and we are asking you to, as reasonably well as you can, begin vaccinating both populations, 65 and older, and those identified in Tier 1 beginning February 1st. We recognize and we are pragmatic enough to understand that if your county is a small county and only receives 100 doses for the week of February 1st, it may not be practical to hit a perfect 50-50 allocation. And there may be plans for how you reach those populations that make that impractical. We want to make sure we look at this more objectively over time and make sure that we reach both of those populations reasonably well. So there is this IDAC reference is only a recommendation. We are strongly recommending that. As we approach our allocation decision making, we are starting with a straight population-based allocation, and we are not influencing that necessarily by distribution of age versus those other priority populations, because for the most part, except for when we reach into the congregate work settings, most of the populations that we are targeting through these various tiers are proportionately distributed across the state, consistent with the state census data. Okay, so again, do your best. Make the best judgment call. It is not prescriptive, but it is an indication we want you to be working on both the age-based population as well as the tiered populations. What category do immunocompromised patients fall into? So right now, Tier 2 is focused on persons with disabilities. If you look at the ACIP recommendations, again, this is from CDC, included for their phase, I think 1C, I'm sorry, I'm forgetting exactly, but the populations under the age of 65 with existing health conditions would be captured by the immunocompromised. So I believe this will be a population that we will address as we advance a 1C recommendation from the IDAC and from a final decision on the part of the department. Are administrative or maintenance staff for law enforcement included as eligible? No, that is not intended to be included at this time. I have received calls from neighboring counties that want us to vaccinate their citizens that may doctor in our county. I understand that it is probably okay to do that, but if doses are being allocated according to population, should that county that is asking allocate some of their doses to provider for to cover their residents? You can certainly discuss that with a neighboring county. Just recall that residency is not a prohibiting factor for obtaining a vaccine. And I think in the end, most of this will work out on its own. But if there are specifically disparate concerns in terms of the number of individuals that are coming to your county from another, I think it is fair to have that conversation with your neighboring county, but the Department of Public Health is not going to negotiate on behalf of either county for that purpose. Where can 16 and 17-year-olds who qualify under 1A and B get Pfizer vaccine administered? Bethany, can you help me here? I mean, any vaccine provider that has the vaccine that can capture the 16-year-olds and above should be able to vaccinate that population. Bethany, anything else to add here?
No, that's correct. That they
Okay.
should be able to look at the website and determine who has where there's Pfizer vaccine and check with those locations.
Next question that we have is, do you know if local doctor offices are helping with vaccinating? I don't think that that's widely practiced at this time, just based on the sheer volume, low volume of vaccine, but certainly if that doctor's office is an enrolled vaccine provider at some point, they may. Again, I would look at your local jurisdiction for specific guidance on where vaccines are available. It is an option, but not likely a regular practice at this time, just due to the low volume of vaccine.
Ken, I do know that several counties that don't have hospitals in their county have been providing those to local doctors' offices and clinics to reach that phase 1A.
Okay, thank you, Rebecca, for the clarification. I appreciate that. If public health workers are not involved in administering vaccine, when will they be able to be vaccinated? That is a population that IDAC pushed off to a later phase. Again, not to suggest that it was a low priority group by any stretch of the imagination. It was really in response to balancing supply and demand. So public health is certainly amongst the population that IDAC is sensitive to, particularly those that have been directly involved with the pandemic response for now 13 months. But at this point, they do not fit within the 1A or 1B population if they are not directly administering vaccines. So Don and Bethany, the final question that I see here is, I know the email I received from Iris indicates if my doses are prime or boost. Is there a way for this to show up in the inventory list?
Thanks, Ken. I was just typing that answer out right now. That is not feasible based upon the current IRIS functionality. So oftentimes that boost and prime doses are the exact same lot number. So we cannot differentiate between that in IRIS currently. We'll have to monitor that and keep track of that outside of the registry. Okay,
thanks, Don. And that's the last published Q&A that I see in the queue here. And we are approaching 1:30. It is now 1:27. I think we will discontinue with our Q&A. We've been able to address 106 questions today, either through staff response directly to the question or through the live Q&A event. So I feel pretty accomplished in terms of getting through that number of questions. My final comments before, Kelly, I'll turn it over to you for any additional final comments. Again, we recognize this has been a very fast changing and intense 2 weeks. We understand completely the difficulties that these rapid changes continue to stress for public health, both at the state and local level. We apologize for that, but it is a reality of the time that we are in. And I think we would just ask to understand that as we watch more information coming out from the Biden administration, we will likely to continue seeing rapid changing events over the next 2 to 4 weeks or more. So please understand that we're doing everything we can to minimize those impacts and minimize the dramatic shifts in changes in policy, but they are unavoidable in many respects at times, and we will adjust accordingly and do everything that we can to support you all, and we appreciate your understanding as we work through those challenges together with you. So with that, Kelly, I'm going to turn to you for any final comments before we close out today's webinar.
I think the only thing that I'd mention, Ken, beyond underscoring what you just said, is that in the next week, I think the areas of focus will obviously be giving you an update on what we learned from the Biden transition team and now full team, as we are dialoguing with them and hope to gain clarity around what the increase in allocation could look like and other details laid out in the plan, as Ken indicated earlier in our session today. We're also will be providing you within the next week additional information around the strike teams and really kind of making sure that folks are have an understanding of what that will look like moving forward. And then additional clarity around other pieces of funding that the state is receiving beyond the 10 million that was indicated today, and that process. And then the last piece is that Medicaid component and how our managed care organizations as a major insurer in the state can play into this vaccination effort. Ken, did I miss anything about for next week's agenda?
No, you covered some things I forgot. So Kelly, thank you very much. With that, we will call a close to today's webinar. We will plan to join you again next week at noon on Friday. Thank you and have a good day. We'll talk to you again soon.